Thank you, Kate. Well, thank you again for having me here, Kate, for inviting me, and congratulations to all of you for making it through the next to last session on a Sunday afternoon when y'all should be probably wanting to go home, right? So, who's treated patellofemoral pain before in this room? Yeah. Anybody not? Ever? Know what I'm talking about? Okay. It's pretty common, that's why I'm asking. Okay, so I don't have any incredibly revealing or earth-shattering evidence to show you that's going to solve the patellofemoral pain problem. But hopefully what we can do in the next 45 minutes to an hour is talk about maybe an approach, other things that I've thought of that you haven't or you've thought of that I haven't in terms of how do we approach these patients. And I'm going to shamelessly steal from Dr. Quinn yesterday in her food analogy. Being Italian, I have to change it to include the Italian heritage. So, I think treating these individuals or a syndrome such as patellofemoral pain, it's like a recipe. There are no two recipes that are the same. In Italy, you can go from one village to the next, literally half a mile, and the recipes are completely different. The dialect, almost the language, is completely different. So the spaghetti sauce is different from one house to the next. So I think for this, we have to kind of think in those same terms. What's the recipe for each patient that's going to work, or we hope is going to work? And it doesn't always come out, sometimes the sauce isn't so good, and sometimes it's really good. So I think if we can think of those terms or have an open mind or think outside the box rather than a rigid set protocol, that's not going to work for this, as probably most of you in this room have experienced. The protocol stuff just doesn't help, does it? All the time. Sometimes it does, sometimes it doesn't. So what is patellofemoral pain syndrome? Whoever really thinks about that? Well, I don't know that anybody really knows because we've got about 16 different names for it. And whenever there's 16 different names for something, it always makes me wonder, do we really know what we're talking about or what we're describing? It's been called, this is just a short list of the terms that have been used to describe this syndrome. Retropatellar pain syndrome, chondromalacia, which we'll find out later, that's inaccurate to describe patellofemoral pain. Chondromalacia patella is a pathologic diagnosis, and I'll show you a picture of that later on. So we don't ever want to use that, although it still is very commonly utilized to describe the syndrome. It's called patellofemoral stress syndrome, patellar tracking dysfunction, runner's knee, lateral facet compression syndrome, and on and on and on. So things aren't always what they seem by the name, correct? So what is this? Anterior knee pain, one definition anyway, anterior knee pain involving the patella and retinaculum that excludes other intra-articular and peripatella pathology. That says to me, we really don't know. It's anterior knee pain. It's pain in the front. It might be coming from the patella. It might be coming from the retinaculum. I don't know that it's consistent in one patient to the next. A lot of people use it as a diagnosis of exclusion, and I think you always have to think of that. And we'll show some examples later on that just because they have anterior knee pain and they're a young adolescent and a female and have some risk factors does not automatically mean that they have patellofemoral pain. I think that needs to be in your differential, but you can't just jump to that conclusion. It is among the most common diagnoses in sports medicine. Nearly 10% of visits to orthopedic and musculoskeletal clinics involve patellofemoral knee pain or have that diagnosis. It does more commonly affect women, and we'll talk about some of the risk factors for that, which many of you probably already know, and it is most common in the second and third decades, typically in active adolescents and adults. So there is an international patellofemoral study group, which I didn't know about before. So they have some terms that they've tried to clarify this a little bit more thoroughly so that maybe there's some commonality in terms of terminology, and when we're talking to each other or referring patients between each other, that we have some understanding of what we're doing. Anterior knee pain is reserved for the patient not yet evaluated. So that's really a chief complaint on the schedule or the presenting complaint in the office. Patellofemoral pain syndrome is used when there's no identifiable cause of pain. Chondromalacia patella is actually a softening of patellar cartilage, so that is a pathologic diagnosis. Luxation or subluxation is complete or partial displacement from the trochlear groove. We've all seen patients that have either dislocated or are subluxing all the time. Incongruence or lacking of fit of the patella into that trochlear groove. Excessive lateral stress syndrome describing an abnormally tight lateral retinaculum causing lateral tilt and high stress on the lateral patella. So even the International Patellofemoral Study Group can't come up with a specific terminology or definition, if you will, for this diagnosis. So what's going on in the knee? What happens that creates this situation? Jenny McConnell, which many of you will probably know the name at least from McConnell taping. How many physical therapists in the room? Quite a few. So you're all familiar with what McConnell taping is. Can be a very, very useful tool. Describe the patella, and I really like this description, as a balance beam that adjusts the length, direction, and force of each of its arms, the quadriceps tendon and the patellar tendon, at different degrees of flexion. So as it goes through its range of motion, different forces and factors are operating to control the movement of that patella. Which right there tells you there's a lot that can go wrong, right? When we talk about the bony anatomy, at about 10 to 20 degrees of flexion, the inferior patella comes in contact with the lateral femur, and the patella is very unstable at that point. So that's when a lot of that luxation and subluxation can occur. In full extension, the patella sits lateral to the trochlea, and then, of course, with help from other structures, can be even further lateral, and depending on the shape of the trochlea, which we'll look at, can affect that position as well. At the 30 to 90 degree flexion point, there's increasing contact within the trochlea and there's more stability, so it's happier there. And the medial patellar facet contacts the trochlea at 135 degrees of flexion, so at full flexion. Does that all make sense? Yeah. I apologize if some of this is redundant or you've heard it before, but I'm just trying to put this all in a framework. So, they have looked at describing patellofemoral joint reaction force. So okay, this is a hinge joint. That patella is supposed to move up and down the groove. What's the problem? Why is there a difficulty? So even though there's just that bony function that we described, there's also soft tissue factors and a resulting vector force that can create difficulty. And that vector force is likely quite different in one individual to the next. So the resultant vector force, and this is physics, sorry, is equal and opposite to the resultant of the quadriceps and patellar tendon tension. So you can see that it goes basically back towards the posterior aspect from the top of the patella. So it's that compression feeling, and that whenever you examine the patient, you can often aggravate their symptoms by pushing down. So that's that resultant force. That force increases with flexion, it increases with walking, going upstairs, squatting, jumping, and the more force that's put on it, the higher the stress and the joint reaction force. So then you have the soft tissue stabilizers of the patella. And I kind of like Jenny's description is there's sort of the ones on the top, the ones on the bottom, the ones lateral, the ones medial. So in the superior direction, you have the rectus femoris, the vastus intermedius, laterally vastus lateralis, IT band, and the lateral retinaculum. Inferiorly, the patellar tendon, and then medially, the VMO and the medial retinaculum. So all of these are operating in a different way with different function at different points of flexion or extension through the knee while they're moving around. And I think we cannot eliminate or forget what Dr. McGinnis talked about for the last hour with the hip, because those factors are very, very important, and there have been some studies that have demonstrated that. So the quadriceps then creates a force vector as well, and the forces come from the fiber orientation of the muscles. So depending on which part of the quadriceps you're talking about, it's going to be a different orientation or direction of that vector force. So the rectus femoris and the vastus intermedius, I know this is not a very clear picture, but that's pulling more superiorly, vastus lateralis, more to the lateral retinaculum, you've got the VMO and the medial retinaculum. So all of those are kind of tugging on this patella, trying to keep it into the right position. So you have to take into consideration those factors as well. The medial patellofemoral ligament excuse me, merges with the VMO, and it is the primary restrictor for lateral deviation. So that's a very important structure. And when you have a patient that's had a dislocation or luxation of the patella, they can often damage or injure or tear that medial patellofemoral ligament. So it's important to make sure that we keep that healthy and keep that in mind as we're rehabbing them. The medial patellofemoral ligament gives more than 50% against the lateral deviation during that initial 20 to 30 degrees of flexion, which, if you remember, is when this joint, or when the patellofemoral joint, is most unstable. As it's starting to move laterally in the trochlea, it's most unstable at that point. So that medial patellofemoral ligament is very important. So we know about the mechanics, but what's the pain coming from? Is it the mechanics? Is it the structures? What's going on? So they have looked at some of these things with different studies. Nobody's come up with a universal, oh, it's this, or it's this, and there's no particular factors or history factors or patterns that they can identify. However, they have been able to identify that there are a lot of free nerve endings that are high concentration in the quadricep and patellar tendon, as well as the retinacula. So if those are structures that are really responsible for moving the patella around or trying to stabilize the patella, if there is abnormal movement, those could definitely respond with increased pain. There's also a chemical reaction or chemical etiology for pain. Substance P increases the sensitivity of the pain receptors, and there's more substance P fibers in the retinacula, in the synovium, in the fat pad, and that triggers a whole inflammatory cascade, which of course is a source of pain. Hyaline cartilage, which is on the surface of both the trochlea, the posterior aspect of the patella, that has no nerve endings. However, subchondral bone does. And if you get chondromalacia, or that softening of that patellar cartilage, that does trigger this chemical synovitis. So which comes first, the cart or the horse, right? Does the chemical issue then trigger development of the chondromalacia? Is it the mechanical factors that contribute? I suspect, as most of us probably do in this room, it's a combination of all of these things, which again gets back to the recipe. The subchondral bone surface is, not cartilage surface, bone surface is very rich in nerve endings. It's very sensitive. Anybody who's broken a bone knows that, right? Increased bone pressure can also develop a process of increased bone remodeling. And if that's that repetitive micro-trauma, if you will, over time, can be a constant source of pain generating. There's been a recent study that demonstrated dysfunction in the afferent nerve pathways, meaning the signaling pathways from the knee joint back to the brain to control pain response in patients with unilateral patellofemoral pain. So maybe there is something about how their nerves work in those patients that have patellofemoral knee pain that make them more susceptible to these mechanical forces. And again, no phenotype, meaning no, it wasn't, blondes or brunettes or redheads, at a certain age. There was no pattern that could be identified that you could say, oh, these are the things that are going to make the pain worse, or these are the types of patients that are going to have more difficult problems. There were no signs or symptoms that you could collect or collaborate on that would identify who was going to have the most difficulty with the pain. So what are the risk factors? I think overload and overuse. We all know that this starts about, 2-3 weeks into a season. They're running more, they're jumping more, basketball particularly, sometimes track season because of high jump and hurdles. They're getting worse because they're just loading more. And not one of them has done any preparation, right, before they end up into their season. I think it also, in my practice anyway, and many of you probably have a similar experience, if there's a fall, a trauma, that they, tripped and fell and hit their knee, that forceful compression of the patella, I think can sometimes trigger development of these symptoms. So sometimes it's truly post-traumatic. That doesn't mean they don't have other factors, but sometimes that's the inciting event. There are studies out there that indicate that there's altered VMO and vastus lateralis response time, where the VMO fired earlier than the vastus lateralis in control group, meaning the non-pain group with patellofemoral pain, creating earlier activation of that medial force vector. And that's kind of, I think, what we all suspect clinically. Can we get that VMO strong enough, first of all? But I think equally important is the timing. Does it happen? Because if the lateralis or the lateral structures are already pulling it here, it's already shifted. So you've got to get that, even if you've got a strong enough BMO, it's a little too late sometimes. There was functional testing done that showed patellofemoral patients with lower strength capacity, measured by vertical jump, and anterior medial lunge, and step down and balance, and reach, and single leg press. Those folks that had difficulty in these strength and functional movements, which kind of gets back to what Dr. McGinnis was talking about in terms of correct position, correct mechanics. So it does seem that there's a connection with this functional movement in their strength and the correctness of the biomechanics of how they move in development of patellofemoral pain. And of course, general ligament laxity can cause more patellar mobility. Are they one of those really loosey-goosey people? And in that case, of course, there is going to be more motion. So we really have to focus on getting that strength and stability. And in my experience, it needs to come from the hip and pelvis almost first, because it's the kinetic chain. You can't treat one joint without treating the other. The Q angle. And this has been, considered the cause and the horrible problem that creates patellofemoral pain for a long, long time. I mean, when I first started practicing, she told you when I graduated. She didn't tell you when I graduated. It was a long time ago. It was thought, oh, well, if they have a bad Q angle, then that's going to, affect them. But how many people come in the office, their Q angle's like 30, and they don't have patellofemoral knee pain? And why is that? Do they have better strength? Do they have, good control? What's their sport? How much are they jumping? So again, it's multifactorial. Is the Q angle important? Yeah, probably. Is there much we can do about it? Not really. And anatomy's anatomy. So I think it's one of those things to recognize and know that there's an issue there potentially of anatomic alignment, but you can't change it. But I think you can do things to try to control the other structures around it. Again, control that kinetic chain through movement so that this Q angle becomes less of a factor. And I think more recently, people have been kind of considering it in that way. Yeah, it's there, it's a problem maybe, but, again, what are we going to do about it? But, 20, 30 years ago, they used to do reconstructive procedures, realignment procedures, breaking limbs to straighten them out. When I did I was still in medical school. There were still hospitals that, if kids had abnormal femoral inversion, they were doing surgical reconstruction, Now, most of the time this was in patients that had a lot of other developmental issues. But nevertheless, that was not all that long ago, still considered to be a reasonable practice. I don't think we're doing much of that anymore, if at all, except in the most extreme of circumstances. So Q angle, something to notice, something to look at, but I don't think it's a definitive factor. Foot abnormalities. We have our foot and ankle surgeon. Absolutely what happens at the foot, right, affects what happens up the kinetic chain. Is that the only issue? And I say this to people, they'll come into the office, oh, well, they pronate. Well, okay, that's probably a factor, but that's not the only issue going on here. I think you have to look at that. And one of the most important things I've learned clinically, get the patient to stand up in front of you without shoes and socks on, with shorts on, so you can see everything and how are they lined up. So what are the factors that you're dealing with? Do we need to consider putting them into an orthotic? Do we need to develop some kind of strengthening? How tight is their Achilles? How does that affect their foot mechanics? And then, of course, their running mechanics. What do they have in terms of, they have a valgus deformity along the tibia? Is it a varus deformity? Gastroc tightness certainly can limit dorsiflexion and creates more subtalar pronation, which then increases mechanically the Q angle. How that plays into specifically patellofemoral pain, we don't know for sure, but I have to think that it's a factor. Again, is it the whole thing? Is it just one of the spices in the recipe? Probably. There have also been studies that have identified a cavus foot as producing increased forces on the patellofemoral joint with running. And I think most of us know if they have a very cavous foot and it's not properly supported, they are going to, when they're running, probably pronate more and not be properly supported. So that could be, again, a factor. Is it something I'm going to look at someone standing there and say, oh, well, you need to go promptly and get, a custom orthotic? Not necessarily, but it's something I'm going to note in my record and say, I want to look at this later on as we work on some of these other things to see, do I need to address that as a potential risk factor and issue for this particular patient? So we have the tightness issue, and hamstrings, the patellofemoral joint forces are increased by slight knee flexion or more quadricep forces to overcome hamstring resistance. So the tighter the hamstring is, the harder that patellofemoral joint has to work. So I think hamstring flexibility or proper flexibility is important. And again, that becomes from, you got to look above. You got to check their flexibility of their hamstrings and quads, because even if they may not be in a sport, they're not a dancer, say, and most dancers, I'll tell you, have ridiculously tight hip flexors. Their iliopsoas is crazy tight, crazy tight. But they can accomplish things because they have joint hyperlaxity and they have that joint hypermobility. So, kids are like, well, I can get my leg over my head. Well, I don't doubt that you can. It's just you're not using the right structures to do it. And so that, I think, is what leads a lot to these overuse, overload situations. Can we do something to improve the degree of overload that particular joint is receiving? The IT band, another factor, increases the lateral force vector. And there was one early study that showed 67% of patellofemoral pain in runners had tight IT bands. And I think, is there a runner out there that doesn't have a tight IT band? I don't know. It's a tough one. I was at ACSM a couple weeks ago, and they were talking about almost like a bursal, like an enthesopathy at that distal part of the IT band, and almost like an adventitial bursa forming there because of that tightness and friction. So I think that's a factor, and maybe another consideration in terms of your differential diagnosis for anterior knee pain. And with the quadriceps, there's consistent evidence in many studies. Many authors have demonstrated that if the quadriceps is tight, or it tends to be tighter in those with patellofemoral pain. Dr. McGinnis already referred to Dr. Ireland's study on looking at abduction and external rotation weakness in both hip pain and patellofemoral pain, and I think that's significant. And one thing that I've done over the last 10, 15 years is spend a lot more time talking to the patients and prescribing more physical therapy directed at that lower core, that pelvic stability, the hip rotator stability, which I think is hugely important. In patellofemoral patients, there have been studies that demonstrated that there were 26% that had weaker abductors and 36% had weaker external rotators. So I think that's real, and I think that's an important piece. And many times I don't think all physical therapists necessarily look at that whole kinetic chain. Of course, no one in this room, right? But many patients come back to me and I say, well, did they work on your hip at all? And they're like, no. I'm like, well, maybe we need to. So again, part of that overall approach. For the hamstring weakness, there was one study that showed 81% of patellofemoral pain patients had hamstring strength deficits. And I think it gets back to that risk of ACL. The quad is way stronger than the hamstring. Now, it's supposed to be a little stronger, but not dramatically stronger. And Dr. Meyer was talking yesterday about some of the studies looking at risk factors for ACL injury have identified that there's a higher incidence of anterior knee pain in these kids in their younger adolescent years. So I really think this is all connected. This can't be, it's not one isolated thing. And the one thing I love about these conferences is I think I've added 5 things since I've been here yesterday and today. I think, oh yeah, that makes sense. That adds to it. So it's really important for us to talk to each other and communicate with each other to figure out what's the best way to take care of the patients. Also, quadricep weakness, VMO strength, and the timing of contraction, as we mentioned, compared to the vastus lateralis. I think that that's, I have to believe that that's a tremendous factor. There was a study that I looked at this past week. It just came in the Medical Science and Sports and Exercise article, and they had done MR evaluation, functional MR evaluation of the quad muscle, and they used parameter of increased signal for hyperemia, meaning more blood flow into muscles after working. And they could not connect that there was a relationship between the function of the quadricep and VMO versus after they had done a bout of exercise. I think it was like 30, maybe 90 seconds of repetitive squat and straighten up, bend and squat type of exercise. I'm not sure, I don't think that really reveals maybe what's really going on. I have to think that it's got to have a role. Is it the entire thing like anything else? No, I don't think so, but I think it's an important factor. I certainly wouldn't say, oh, well, we don't have to do any VMO strengthening on these kids just because of that particular study. But I think more people are starting to look at it and look at it in more objective and quantitative ways, which I think is going to be very helpful for us in the future for figuring out this problem. So let's talk about history. I mean, this is where I do most of my stuff. People come into the office. Their common complaint is a diffuse anterior knee pain. I'll always ask, can you point for me with one finger where it hurts? And what do? They put the hand right over their knee. And they go like this, exactly right. It's all around here. Okay, can you be more specific? Yeah, all around here. Okay, got it. Sometimes they may not see swelling or appreciate swelling, or the parents don't appreciate swelling, but it feels swollen. It feels full. It feels tight. It doesn't feel like it's moving smoothly or normally. They often have pain with steps. They'll experience this giving out. How many times do they come in and say, my knee gave out on me? Well, I'm not sure it really did. I think that's quad inhibition. The quadricep kind of knows. It's probably smarter than the kid. We shouldn't be doing this. I'm not going to do this because it's going to hurt. And so then it gives out. The theater or movie sign, when they sit for a long time, how many times they tell you, I can't sit in the car if it's a couple hours, my knee's killing me, or I can't sit through school, I have to straighten out my knee, that kind of thing. What's happened recently with their training? Again, let's see, we're at the finish of most school sports, right? There's a couple weeks left. I predict in about another month, as they're all doing camps and everything else, they're going to come in and start fussing about their knees because they haven't been prepared, or they go, and what we see in this area, because we have many ballet intensives, these kids dance maybe 8-10 hours a week, then they come in and they dance for 5 or 6 weeks, 8-10 hours a day. That's a huge jump, and not one of them is going to give up or stop early or whatever because they're fighting for a spot or the best class or whatever. So I think we have to really understand what they've been doing. They may not think of it as abnormal. I say, have you done anything different? No. Okay, well, what were you doing a month ago? Oh, I started this new something or other. So they may not bring it. It doesn't connect for them to be a factor in what they're doing, and that's where we can educate them in controlling that volume of training and stress and overload that's placed. They'll also often describe a crepitus or popping sensation. So the physical exam. Oftentimes it doesn't show us a whole lot, does it? I mean, you might have some painful spots. Sometimes that medial patellofemoral border or retinaculum is kind of tender. Sometimes you'll feel a plica. Don't typically feel an effusion. But every patient that comes in gets the same knee exam for me. Because just because they have anterior knee pain doesn't mean that I'm only going to look at the patellofemoral joint. I need to check the joint line. I need to check for bony tenderness. I need to check their ACL. I need to look at their range of motion. I can't just focus on that one joint because you might be missing something, especially in the musculoskeletally immature athlete, because there's many things that can be there that might present with classic patellofemoral pain, and it's something completely different. So always, always, always do the same exam on every patient and think through a differential every time someone comes in there. Just because it sounds, we have a saying in medicine, if you hear hoofbeats, think of horses, not zebras. However, the zebras you still think of, you just think of the horses first. Okay. You want to assess for findings that may indicate other diagnoses in the differential. Remember, especially in the younger kids, knee pain can be referred from the hip, or it could be referred from the back. They don't know. All they know is their knee hurts. So you have to make sure, even if it's just a quick question, do you have pain anywhere else? Or have you had any other injuries? Did you hurt your hip? Young kids, young boys particularly, can have slipped femoral epiphyses and present with knee pain, but not hip pain. So keep in mind the age and skeletal maturity of the patient. And, as a physical therapist, you may be the second line, and the physician may have not figured this out. But if you see a red flag or something that doesn't make sense to you, you need to bring it either to the parent's attention or to our attention. So I look at flexibility on all of these kids. Now, it's not nearly the degree of accuracy that you in the physical therapy world can measure. I don't necessarily use a goniometer. I do more the eyeball thing. But for me, I want to see about how tight are their hip flexors. Are they, and most of them, you don't even have to do the Thomas test. You don't even have to put them to the end of the table because they're already so tight. What's their IT band like? Is their Ober positive? How tight are their quads, their hamstrings, their Achilles? Hamstring, I typically use the popliteal angle as a measure. I also stand them up and look, what's happening with those knees? She comes in with right-sided knee pain. Gee, I wonder why. But I can't be misled to think, okay, well, it's just that. Her Q angle, probably 30-ish. But that's not the only factor that we look at, just pure standing there. So hamstrings, I think it's pretty easy in the office, because we're all pressed for time, and we don't necessarily, we may have 15 or 20 minutes to assess the patient, including, history and exam, but this can give us a very nice idea of what's going on. The Thomas test, as I mentioned, and most of you are familiar with, Eli's test, looking at their quad flexibility. And Dr. McGinnis has already demonstrated very nicely the Trendelenburg test. I just get them to stand up and, again, barefoot with shorts on and pick up one foot. Can they stand there, or are they all like this? And the dancers, too. Don't be misled. Just because they're a dancer doesn't mean they have good pelvic stability. Not automatically, okay? The single leg squat, again, she showed that very nicely. I did have a kid last week, though, that was able to go fully down to the floor and back up on both sides and not move. It was the first time, I think it was the first time I've ever seen it in 20 years. So kudos to him. The step test, or the side step test, again, you're looking for that valgus position of the knee, which suggests that, weakness of the abductors, overcompensation of the adductors. Maybe it's their foot alignment, their pelvic stability, their hip strength, or all of the above, most likely. I think it was it Dr. Meyer's lecture yesterday? He had the skeleton. Were any of you there? Yesterday he had the skeleton that did the dynamic, the jump down. And see how that pelvis was rotating? It was crazy, right? I'm sure that's what's happening with half of these kids. And it's no wonder the knee hurts, right? Patellar tests. Many of you might be familiar with these or not. I'm happy to go over them afterwards if anybody has any particular questions. We do the Clark's test, or I do the Clark's test, where you compress the quadricep tendon, have them tighten the quad tendon, and it tends to really enhance the shift if they have one. It often hurts them, so if I really think it's patellofemoral pain, I'll leave that one for last because they're not happy with you after that. So I tend to start with glide and tilt. How much can they move? How easily do they move? Are they really loose? Are they really tight laterally? How much can I tilt it? What's the mobility of that patella like? Does it hurt when I push down? Is there tenderness along either the medial or lateral facet? And then I hit him with the Clark's test. And I'll most of the time do x-rays. Do an AP and lateral, and especially in the immature musculoskeletal individual. The merchant in the skyline, you can talk to 15,000 people. Some people like one versus the other. Basically what you're looking for, of course, is the placement of that patella within the trochlear groove. So on the left is the merchant, which is shot from above at about a 45-degree angle. And you're looking for that alignment. You're also looking for the depth of the trochlear groove. Skyline is shot from below, kind of looking up like you would at a skyline. And again, you're looking for placement. You're looking for the depth of the groove. And many times you'll see a very tilted laterally patella, which in and of itself it's not like, oh, we have to move the patella. It's just a factor. It's like, okay, it's already tilted into the lateral side, so maybe we really need to look at those medial forces and what's happening and how powerful are they. The tunnel view, and this was an actual on the far right was an actual patient of mine, came in. He actually was a male, was not a female. He was about maybe 14, and I would have bet any amount of money that this was patellofemoral knee pain. He had the classic story. It hurts when I sit too long. It's kind of achy. I don't know where the pain is. I said, he's 14. He just grew, or he looks starting to go through a growth spurt. I'm going to get the films. And you can see on the medial femoral condyle, sort of that extra piece of bone, that's an OCD, an osteochondritis dissecans. Huge piece. So if we had not done the x-rays and that had gotten missed, this child that would have broken off and moved later. And he would have been looking at probably arthritis and major procedures to reconstruct that. So it's not always, things aren't always what they seem. So you always have to have those zebras or those more unusual things in the back of your head, especially if something's not quite right about it. Are they not responding? Or something about the exam or something about the history that just doesn't quite add up. Go that next step, look that next step further, because you might find something that really needs to be addressed in a completely different way. This is chondromalacia patella. See that kind of fibrous, almost looks like a jellyfish kind of thing to me. That's the softening, almost fibrillations, like fluffy kind of degradation of that articular cartilage. So that's actually chondromalacia patella. The only way you can make that diagnosis is sometimes on an x-ray you can see sort of an irregularity or calcification that would lead you to suspect it, or it's an MRI or CT diagnosis or arthroscopic diagnosis. So if someone comes to you and says, oh, I have chondromalacia patella, and they've not had any of these imaging studies, they may not. Not to say that they don't have patellar pain, but they may not have the advanced stage of chondromalacia patella. There are some studies out there. They're trying to figure out what happens. We kind of assume or we extrapolate what happens with the knee joint from cadaver studies, but they're trying to do CT studies to see, what happens to that patella at 15 degrees, at 30 degrees, 45 degrees, to see what happens to the alignment. And is it the same in everybody? Is there a control? Is there a norm that you can set up and establish that then someone will deviate from to help you? The kinematic MRI, the study I referenced, I think is going to be a very useful tool. It's not cheap, but I think that it might help us, even in a research fashion, to identify what other issues might be at play. And if someone, MRI I use to assess the cartilage primarily, especially in that patient, again, that they've had a bunch of subluxation, or there's something they're just not responding well to the conservative management. Is there chondromalacia patella? Is there a chondral defect? Is there an early OCD I can't see on the plain film that's coming into play with this? I don't necessarily do it right away, but if I, in the 2-3 months of working with them, don't get very far, I'm often thinking, okay, do I need to do another study to look for that other thing that I might need to treat differently? So how do we treat them? Pain management, which is so individualized and difficult in each patient, because everybody has a different appreciation of pain. Some appreciate their pain much better than others. And I think there are a lot of factors, as we talked about, are their nerve pathways more sensitive? Do they have more softening of that, or have more compression forces on that subchondral bone that's causing more of their pain? I think initially it's very appropriate to do ice, nonsteroidals, modality treatments in physical therapy. Acupuncture has been shown to be very effective, and I use that a lot, especially in the folks that they're so painful they can't even do anything to try to get out of the spiral that they're in. And I think that can be a very useful tool. There have been a lot of Cochrane reviews on treatment interventions for patellofemoral pain. The one showed limited evidence of effective pain relief with nonsteroidals. One nonsteroidal was not superior to another. So no matter what the drug rep tells you, I'm not offending any drug reps, I hope, one medication is going to work well in one person and not necessarily in the other, and I think that's just the nature of humans and physiology. There was limited evidence that nandrolone may be an effective treatment. Does everybody know what nandrolone is? Anabolic steroid. Probably not the thing we want to treat with. So obviously that was not recommended. I don't know how they got funding or IRB for that one, but interesting. Ultrasound therapy did not seem to show any clinically important effect on pain relief, but I think we all know that there are some patients that respond very well to it. So I think it's a reasonable thing to consider. And unfortunately, the studies that did look at it were of poor quality, and of course, as always, more research recommended. Probably the strongest evidence we have is for effectiveness is in acupuncture. And is that because, you've got that chemical reaction, you've got the mechanical factors. Does something about the acupuncture or, the trigger point injection, as Dr. McGinnis was talking about, does that reset those processes, those physiologic processes? I suspect it does. And it's one of those things I always say, it might help and it's probably not going to hurt. Now, there's no teenager that goes, yeah, sure, stick me with needles. But most of the time we can talk them off the ledge and convince them to give it a try, because if any of you had acupuncture? Yeah. Does it hurt? No. You can't even feel it. And I always tell them, your pain you're having right now is worse than anything the acupuncture is going to cause. So consider it. But sometimes they need some convincing. Exercise treatment. Cochrane review again looked at 12 trials that were focusing on exercise therapy in patellofemoral patients. 4 of them were considered of high quality. There was limited evidence that exercise therapy is more effective than no exercise for pain reduction in treating patellofemoral pain symptoms, and conflicting with respect to functional improvement. I don't know that I believe that. Sorry? It was kind of, yeah, exactly. I think, what were they doing for exercise? Right, exactly. So I think, and that's kind of what their point was in the Cochrane review, that it probably wasn't designed correctly, nor did they have a wide range enough of exercises or specifically or uniquely prescribed types of exercises. There was strong evidence that open and closed kinetic chain exercise are equally effective. But I think we all know, and in my experience more recently, since I've been seeing more of these patients since being at Boston Children's, I think there are some that do fine when they move directly to the closed chain exercises, but I think there are a lot of them that start that stuff too soon, and it just makes them worse. And again, not picking on anybody in this room, but I think some therapists just think, oh, okay, wall squats are the thing to do for patellofemoral pain. Well, that may be 6 months in for some patients. So I think it really has to be individualized. I think you have to look, again, at your patient, what the limitations are, what the flexibility issues are, what their core strength, their pelvic stability is. And I think all of those things have to be started sometimes at very baby steps. Even though they might be very accomplished athletes, doesn't mean that they have all the tools that have been developed, because the sports programs, as we all know, just don't provide that training, that instruction. Parents are constantly, but I send them, they go to this, I know, but they're not, whatever they're doing isn't working, obviously, so maybe we need to kind of look at them as an individual. And again, nothing against coaches, but coaches may or may not have the training or knowledge or ability or time to go through and watch 25 kids do their stretches correctly, or make sure that they're all doing the strengthening exercises that they need to. They may not even know that that's important, because so many of them are just volunteer parents, right? So I think that more education, more information getting out there. There was a study from Belgium showed that increased quad size and lower eccentric strength and less pain have better short-term outcome with exercise treatment. So there was a subset, they felt, that did better with the exercise treatment. But I can't believe that just by examining most of the kids that come in with patellofemoral pain, as I'm sure most of you in the room, that there's not something that we can make better with exercise, especially if they're athletes. And this was the other question I would ask: how many of these were actual athletes? How many when there were, the couch potatoes or the math geeks or whatever that aren't doing much in terms of sports? So even if it didn't make much difference in their pain for activities of daily living, if you're challenging that body as an athlete, it's got to help. I mean, you've got to do it. Orthotics, bracing, taping, evidence was of limited quality, and they felt that high-quality studies were encouraged. I use taping, I use orthotics, I use bracing. I can't say that I have one set thing that I go through. I often say, talk with your physical therapist. Try the McConnell taping, maybe some kinesio taping. Let's try a patellofemoral brace if you really feel like it's worse when you're active. Let's see if it helps. I can't guarantee it, and it's not something that I think you have to do, but it might be worthwhile as a short trial to see if we can make anything improved. So I think to get back to the big picture, the big recipe, we have to assess each patient as an individual. We have to look, we have to get the good history. We have to do the good physical exam, get the diagnostic studies that we need. And then we have to look at their risk factors. We have to see what activities are they doing. Can we simply improve this by saying, what, maybe you need to cut back, half of your practice on 3 days a week or something to diminish the load and the overuse trauma that's occurring onto that patellofemoral joint. What are your exam findings? What are your imaging results? And I think you need to consider the treatment options, look at what's in front of you, form a plan, send them off, have them come back. Make sure you follow up. If you don't follow up, you don't know what's going to happen. Many times they come back and they're just frustrated. Well, I did the exercises for 2 weeks and I'm still in pain. Well, that's not going to help. This is going to take longer. They need to be reassured. Sometimes they need their hand held through this process. Maybe you need to think about, okay, maybe I missed something. Maybe there's another diagnostic study that I needed to do. Do I need to change the approach? Do we need to change what we're doing in physical therapy? It's a bit of trial and error. And I think if you explain that to parents and patients from the get-go, they're like, okay, I can do this. Sometimes not. They're like, I want to fix now. But that's not always realistic, obviously, as we all know. So those are the references, a lot of them that talked about these studies that I referred to.